It's a pleasure to welcome you to the second webinar in the series from the Pan American Association of Ophthalmology. This is an update of a course that was presented at the Pan American Research Day in Fort Lauderdale in 2012. I'm Dr. Timothy Murray, who will be directing this session, and I'm currently a Professor Emeritus of the Bascom Palmer Eye Institute in the Sylvester Comprehensive Cancer Center. I practice within the Ocular Oncology and Retina Service in Miami, Florida. It's a real pleasure to have the opportunity to speak with you today. I'm going to present a scheduled lecture, and then we'll do questions from the audience at the end of the lecture. We hope that this will be an approximately 55-minute presentation, and we look forward to the opportunity to interact with you today. I have no financial disclosures relevant to this talk, but it's important to realize that I'll be discussing both innovative care and the use of off-label drugs and devices in the care of children with retinoblastoma. Retinoblastoma is the most common primary intraocular malignant tumor in children. It affects typically 1 in 15,000 children born in the United States and throughout the world. Current treatments have evolved from enucleation or removal of the eye to include systemic chemotherapy, laser ablation, external beam radiotherapy, and currently focal chemotherapeutic strategies that we'll discuss today. Unfortunately, advanced tumors respond poorly to current treatments, including advanced chemotherapy and laser, and failure rates have been reported as high as 75% for advanced stage retinoblastoma. It's important to recognize the presenting signs and symptoms for this disease. Leukocoria, known as a cat's eyes pupil or widening of the pupillary reflex, is seen in approximately 60% of children with retinoblastoma. Strabismus is seen in approximately 20%, and rarely, less than 10% of children present with a red or painful eye. Well baby examinations detect only about 3% of these children, and we're keyed into evaluating children for retinoblastoma when there's a known family history. This is an example of leukocoria. This child looking at us has a bright red reflex on the right eye, and the left eye presents with this white leukochoric reflex. Underneath, the child presents with a combined leukochoric reflex of the left eye and a sensory strabismus with a left esotropia. The child to the left here presents at Christmas time with leukocoria in the right eye. This family was not worried about this child because their dog presented with leukocoria in the left eye, and they felt that this was normal. Unfortunately, their dog had a cataract in the left eye. The right eye for this child had advanced retinoblastoma. There are two major classifications for retinoblastoma. There is the Reese-Ellsworth staging system that was developed to evaluate the response to retinoblastoma treatment with radiotherapy, and there is the current international classification of retinoblastoma. At our institute, we use both of these classifications when we evaluate children with disease. Early stage retinoblastoma is typically intraretinal, and for Reese-Ellsworth, it represents stages 1 through 4. For international classification of retinoblastoma, it represents stages A and B and early stage C. Retinoblastoma, when it first presents, is typically a translucent white-gray lesion within the retina. It shows dilated intratumoral feeding vessels, and there may be microcalcification. This is a low and high-power RetCam image of a moderate-sized macularly located retinoblastoma in one of the children that we manage. You see the optic nerve, the fovea center, and the classic lesion here, which shows intratumoral calcification, that is chalky white, a salmony white fish flesh appearance to the tumor, and with close evaluation, There is vascular engorgement with intratumoral vessels. More advanced retinoblastoma shows an increase in size of the lesion. In this case, this child's left eye shows leukochoric alterations, as we've seen, and has a primary macular retinoblastoma. This tumor shows an intra and subretinal component of the tumor, an associated exudative retinal detachment, and focal blot hemorrhage. Of note, it's critically important when evaluating a child with retinoblastoma to evaluate both eyes. And in this child's asymptomatic right eye, with no evidence of leukochoria, we see a very subtle, early macular retinoblastoma tumor, fish flesh appearance, focal microcalcification within 200 microns of the foveal center in the right eye. Advanced retinoblastoma typically presents as a large tumor mass with both vitreous and or subretinal seeding. Retinoblastoma is a non-cohesive tumor that leads to seeding or shedding of tumor cells into the vitreous or subretinal space, and this seeding can even extend into the anterior segment, leading to an iris nodule presentation or a pseudohypopyon that may be mistaken either for uveitis or endophthalmitis. Rubiosis iridis is seen with advanced disease and represents vascular engorgement of the existing iris vessels and secondary neovascularization, and this can lead either to spontaneous hyphema or to neovascular glaucoma. Tumor necrosis is rare, seen in less than 5% of these patients, and is typically associated with marked intraocular and periocular inflammation. This is an example of advanced retinoblastoma with leukochoria. You see here the leukochoria in this child's right eye, and you can see the soft seeding of the vitreous directly behind the lens. Here we see a more dense leukochoric alteration, and you see the heavy seeding of the vitreous and the fine microseeding of the vitreous, again in this child's right eye. We've seen unique evolution in treatment trends for retinoblastoma. When I joined the Bascom Palmer Eye Institute faculty and directed the ocular oncology service beginning in 1991, 85% of the children over the prior decade had been treated with enucleation. By 1991, 85% of the children with retinoblastoma were being treated with external beam radiation therapy, and only 25% of the children were enucleated. A decade later, in 2001, we had shifted entirely from external beam radiation therapy to systemic chemotherapy, and now 85% of children with retinoblastoma were treated with systemic chemotherapy, and only 10% of the eyes were enucleated. And in this last decade, in 2011, we've moved from systemic chemotherapy to focal chemotherapy, where we deliver chemotherapy directly into the ophthalmic artery utilizing an intra-arterial approach, and we now treat 90% of children with retinoblastoma with this focal chemotherapeutic approach that spares them exposure to systemic chemotherapy, and enucleation rates now are below 5%. It's important also to remember that our focus when we manage children with retinoblastoma is different from our standard focus as an ophthalmologist. We're more interested in these children in making sure that they are alive and well, so survival is our primary goal. If possible, we want to retain their globe, and we would like to do that with functional visual acuity. One of the major focuses of our laboratory has been to evaluate treatments and improve treatments to decrease treatment-related morbidity. There are many controversies that still exist in the management of pediatric retinoblastoma. One of the most important is the treatment approaches for advanced retinoblastoma with either vitreous or subretinal seeding, which is Reese-Ellsworth stage 5B, or the ICR classification stage DE. We still remain uncertain of the mechanisms for tumorigenesis in retinoblastoma, and we continue to search for alternative novel strategies to improve local retinoblastoma tumor control while decreasing treatment-related systemic and ocular morbidity. I'd like to present with you an intraocular retinoblastoma tumor control study from the Bascom-Palmer Eye Institution that was IRB approved. We evaluated children treated with retinoblastoma from 1996 to 2002 on our pediatric retinoblastoma service. All children had Reese-Ellsworth stage 1 through 4. That's disease that did not include vitreous or subretinal seeding and would be currently classified as ICR stage A through C. What was unique about this study was that all children were prospectively treated with a single treatment protocol. They received 3 chemotherapeutic drugs systemically: carboplatin, which is the mainstay of therapy, vincristine, and etoposide. All children had a minimum of 6 cycles up to 9 cycles of systemic chemotherapy, and the chemotherapy was delivered every 3 to 4 weeks. Uniquely, every child was treated prior to the institution of systemic chemotherapy with examination under anesthesia and laser tumor ablation to the tumor surface of all tumors within both eyes. We documented tumor response and tumor status with wide-field RETCam fundus imaging, high-resolution echography, and recently with intraoperative spectral domain OCT. There has been a controversy about the number and type of drugs chosen for systemic chemotherapy. At some institutions, etoposide is not used because of the concerns for systemic secondary leukemia. We have not seen that at the Bascom-Palmer Eye Institute. At some institutions, vincristine is not used because of concerns for cardiac toxicity. Again, we have not seen that complication at our institution. In our series, we had 149 eyes from 119 children, pretty evenly split between girls and boys, and the mean age at presentation was approximately 14 months, with the earliest child treated at 3 days of age, and the latest child in this series treated at 5.5 years of age. This is the example or typical case in this series of an 11-month-old boy who presents with leukocoria over 1 month. His vision in the right leukochoric eye was central and steady but unmaintained, and in the left eye was central, steady, and maintained. He had a Reese-Ellsworth stage 3 retinoblastoma and an ICR classification stage C with a unilateral unifocal macular tumor. In this case, you see the large tumor that abuts and obscures the optic nerve, an endo and exophytic component of the tumor, and a complex retinal detachment. This child was treated with laser therapy directly to the tumor and 9 cycles of 3-drug chemotherapy with carboplatin, vincristine, and etoposide given every 3 to 4 weeks. On the 4th cycle of treatment, this child on chemotherapy developed a new tumor, which made it clear that this was an RB1 germline mutation and that this child had both an ocular and systemic risk. We were able to follow this child over 10 years from treatment, and this child now in that right eye, which would have been enucleated historically, is 20/50, and the left eye is 20/20. This is the right eye after 1 cycle of chemotherapy. Notice the optic nerve now is visible. The macular tumor has significant regression in the primary tumor. There is marked calcification, and the exudative retinal detachment has resolved. This is after 3 cycles of chemotherapy and shows the tumor after laser treatment in the operating room. And this is the tumor now 10 years after treatment. Here is the second tumor that presented. This is the calcification from the vitreous fine seeding. This tumor is totally regressed, and remarkably, the vision in this eye is 20/50. Our series in its entirety had a mean follow-up of 82 months, and a range in follow-up from 44 months to 123 months. As would be expected, all of these children are alive and well. We had tumor control in 149 of 149 eyes. No eye required enucleation, and no eye required either plaque or external beam radiation therapy. New tumors, like we saw in this child, developed in almost 20% of the eyes, and the visual acuity had a mean of 20/40 and a range from 20/20 to 5/200. At the same time, we evaluated our series of advanced stage 5 eyes that were ICR classification stage C or D from the time period 1996 to 2002. These are the eyes where there have been failure rates reported as high as 75%. In our case, fortunately, we had tumor success for control in 78% of the eyes, but 40% of the eyes developed new tumors on therapy, and 50% of the children had treatment-related toxicity that included myelosuppression or fever of unknown origin that required hospital admission and hospital evaluation and management. When we evaluated the 22% of eyes that failed, it was remarkable that every single eye that failed from either vitreous or subretinal seeding. No eye failed from the primary retinal tumor. So the clinical conclusions that we take home from this are that virtually 100% of children today presenting with retinoblastoma should be able to be alive and well. There's been a significant shift over 3 decades from enucleation to external beam radiation therapy, from external beam radiation therapy to systemic chemotherapy, and from systemic chemotherapy to focal chemotherapy. Systemic chemotherapy, though it achieves excellent tumor control and outcome analysis success, is severely limited by toxicity related to treatment, particularly chemotherapy-associated myelosuppression. And when eyes fail systemic chemotherapy and are required to be enucleated, they always fail associated with seeding of the vitreous or the subretinal space. So what have been the trends that we've looked at within the Ocular Oncology Laboratory at Bascom Palmer and the McKnight Vision Center? Our interest has been to improve the treatment of retinoblastoma and to use a unique animal model that develops tumors identical to pediatric retinoblastoma, and our focus has been to evaluate changes in the retinoblastoma tumor microenvironment and to use that microenvironment to target novel therapies. Pediatric retinoblastoma may be the primary prototypical example of a vascularized tumor. It has in fact been shown that angiogenesis staging of retinoblastoma is predictive of the development of metastatic disease in children that present in less developed countries. Animal modeling has the possibility to allow us to evaluate vascular therapies that could enhance tumor control as both adjunctive therapies and as novel primary therapies. This is an example of the tumor progression in this animal model. At 4 weeks of age, we see no clinical disease. By 8 weeks of the age of the mouse, we see small tumor. By 12 weeks of age, medium tumor. By 20 weeks of age, large tumor. Here's small tumor in this animal at 8 weeks. Here's large tumor filling the eye in this mouse at 16 weeks of age. Notice that this is a small blue cell tumor identical on histopathology to retinoblastoma. We've had an interest in blood vessel patterns in tumors as a potential for treatment, and our first step was to evaluate both immature or new vessels and mature vessels in eyes containing retinoblastoma. Here you notice at 8 weeks of age, green immunohistochemical staining showing new or angiogenically novel vessels, and red showing mature vessels. At 8 weeks of age, virtually half of the vessels in the tumor are new vessels. By 12 weeks of age, we see a shift to more mature vessels, and by 16 weeks of age, we see a significant maturation of the abnormal tumor vessels in the retinoblastoma tumor eye. It's important to recognize that animal models may differ from the human condition. And this was a study that looked at 10 eyes that were enucleated without any prior treatment for advanced retinoblastoma and evaluated for immunohistochemical analysis for immature or novel new vessels and mature vessels. And this is endoglin, which stains for new vessels. This is combined staining of total vessels. And this is evaluation of smooth muscle actin showing mature vessels. And what we were able to see in this series is that human retinoblastoma eyes exactly mirror the mouse retinoblastoma model in both having immature and mature vessels as a potential target for therapy. So now knowing that there is a unique blood vessel pattern in retinoblastoma tumors, we evaluated the potential to use blood vessel vascular targeting to both increase the response to standard chemotherapy and to target a potential to increase or decrease tumor-related hypoxia. Hypoxia targeting has been suggested to be beneficial as hypoxic cells tend to be resistant to both chemotherapy and radiation. We've used a novel metabolic strategy using 2-deoxy-D-glucose to eliminate hypoxia in this animal model. So our experimental focus was to evaluate for the presence of hypoxia in retinoblastoma tumors, to utilize vascular targeting agents to either increase hypoxia and secondarily alter the microenvironment, or to utilize glycolytic inhibitors to eliminate hypoxia and potentially enhance tumor control. To evaluate for hypoxia, we used a unique compound called pimonidazole, and pimonidazole detects hypoxia through the binding of thiol-containing agents, and it only occurs in cells under low oxygen tension that are hypoxic. In this study, hypoxia is seen with immunohistochemical staining of the pimonidazole and is green. In small to moderate tumors, we see very little hypoxia. In moderate to large tumor, we see increasing hypoxia. And in very large tumors, we see advanced hypoxia. That's kind of what we would have expected clinically, where we believe that as these tumors grow rapidly, they outstrip their vascular supply and they don't bring enough hypoxic presence to the tumor to allow it to survive. So now that we know that there's significant hypoxia, particularly in late-stage retinoblastoma tumors, it gave us a targeted strategy for a novel treatment. And the treatment that we utilized was to alter tumor metabolism in the retinoblastoma tumors by using an inhibitor of glycolysis, 2-deoxy-D-glucose. What's unique about 2-deoxy-D-glucose is that it is in fact a sugar analog. It is not a chemotherapeutic agent, and it affects only hypoxic cells, but it induces cell death in hypoxic cells within 24 hours of exposure, and it does this by blocking glycolysis by suppressing hexokinase, an enzyme that is responsible for the initial metabolic step in glycolysis. To evaluate this in the targeted animal model, we used 2-deoxy-glucose with and without carboplatin. We treated these eyes with periocular delivery of drug. We did not use systemic chemotherapy, and we treated animals with both moderate and large tumor burden. To have a statistically significant sample size, we used 12 animals per group, and we evaluated hypoxia at both 1 and 7 days with pimonidazole. And what you see here is the control group shows significant hypoxia. Carboplatin treatment does not show a significant reduction in hypoxia. 2DG shows a marked reduction in hypoxia, and the combination of 2DG plus carboplatin eliminates hypoxia in this animal model. So that's an interesting laboratory documentation of the effect. But from a clinician's perspective, what we're truly interested in is, can we reduce tumor burden in children with retinoblastoma through the use of this drug? And to do that, we use the same animal model and the same drug combinations, but now instead of looking at the impact of hypoxia, we looked at the reduction in tumor. Here's the control eye. You can see the eye is massively filled with tumor. This is the eye treated with carboplatin alone. There's still tumor, but a significant reduction. The combination of carboplatin plus plus the 2DG has virtually eliminated tumor here in this eye, showing a significant benefit of 2DG in the reduction of tumor burden when combined with carboplatin. But look here, this eye has been treated only with 2DG without chemotherapy, and the effect in tumor reduction is equivalent between 2DG and carboplatin chemotherapy, a remarkable result for a non-chemotherapeutic agent. So in this animal series, the T antigen LH beta model exhibits hypoxia that mirrors that seen in children associated with advanced late retinoblastoma. The use of 2-deoxy-D-glucose has the ability to significantly decrease tumor burden, but the combination of 2-deoxy-D-glucose as an adjuvant therapy with carboplatin resulted in the total elimination of intraocular retinoblastoma tumor in this animal model, and suggested that vascular targeting therapy and hypoxic modulation may be important clinical targets. So we conclude that vascular heterogeneity, both new and mature vessels, is the hallmark of advanced retinoblastoma. We've concluded that animal modeling studies can predict the response of pediatric retinoblastoma eyes, both to current and to novel therapies. And we suggested the potential benefit of the use of a glycolytic inhibitor such as 2-deoxy-D-glucose as both a primary and combined treatment strategy for retinoblastoma. So what's new clinically in 2012? I'm going to talk to you about what I think is one of the most significant advances in clinical therapy in retinoblastoma that has occurred in the last decade. First, I'm going to talk about the use of salvage therapies. There's two therapies that we've initiated as a salvage therapy. One is the use of periocular chemotherapy, where we inject chemotherapeutic agents around the eye, and the other is the use of intra-arterial chemotherapy using an ophthalmic artery delivery. And then after the discussion of the use of these agents as salvage therapies, we're going to discuss where those agents play a role in primary therapy for retinoblastoma in 2012. I'm going to start with a case. This is a 7-year-old Greek girl who presents with unilateral, multifocal, advanced stage 5B retinoblastoma with an ICR stage CD classification. She has seeding of the vitreous, and historically this is an eye that would have been enucleated. She has no family history. So what are our treatment options today? She's 20/20, her anterior segment is quiet, and she presents with this clinical picture. Notice the right and left eye look very good, but on closer evaluation you can see there's some abnormalities of the vessels leading to the optic nerve, and we suggest how important the entirety of the clinical evaluation is. So when you look at this right eye and you look nasally now with wide field imaging with indirect ophthalmoscopy, you see an advanced retinoblastoma tumor with an endo and exophytic component, focal retinal detachment, and vitreous seeding. What we could not photograph is very anteriorly in the same eye, a separate and independent focus of retinoblastoma superiorly that tells us that this child has an RB1 germline mutational alteration. So what would we have done? Historically, we would have enucleated this eye. Now, in the last decade, we would have used 9 months of systemic chemotherapy, and focal laser ablation. But today we're going to talk about the use of focal chemotherapy. So what do we mean by focal chemotherapy? Focal chemotherapy is the delivery of chemotherapy without using a systemic intravenous delivery system. And we've evaluated novel ways to deliver chemotherapy by either injecting chemotherapy around the eye. We've utilized periocular delivery. We've used evaluations of depot or gel or polymers, and we've even evaluated the placement of miniature catheters. This is the use of periocular carboplatin that is injected around the eye without systemic delivery. What's unique about this is that it utilizes 1/10 of the systemic dose, but delivers 10 times the concentration of the chemotherapeutic agent to the drug. The Children's Oncology Group in the U.S. is now involved in a multi-centered trial evaluating the use of periocular carboplatin chemotherapy combined with systemic chemotherapy in children with advanced retinoblastoma. This is the first child that was ever treated with periocular chemotherapy alone. He presented with a small tumor that showed progressive enlargement and activity. This is the first injection of the chemotherapeutic agent. Here's the intraoperative ultrasound, the wall of the eye, small tumor focus, and this is the depot or the injected drug, the carboplatin that layers right against the wall of the eye adjacent to the tumor. And this delivery of drug allowed this tumor to be controlled and this child to maintain 20/20 visual acuity without ever requiring systemic chemotherapy. The alternative to periocular or intraocular delivery of drug is the use of intraarterial infusion. Intraarterial infusion of chemotherapeutic agents was pioneered in Japan and was brought from Japan to the United States by the group at Memorial Sloan Kettering under the direction of Dr. David Abramson and Dr. Pierre Goban. We utilized this treatment initially in salvage eyes that were scheduled for enucleation that had failed systemic chemotherapy. We now use this as primary treatment. The initial drug of choice was Malphilan because that was the drug that was most exhaustively evaluated by the Japanese, but most of the advanced treatment centers now are using Malphilan, carboplatin, and topotecan either alone or in combination. You can see here this is the direct intraoperative arteriogram where the catheter is placed here and the drug is pulsed along the ophthalmic artery, and you can see the blush showing the perfusion throughout the eye. So to perform this procedure using a modification of the Japanese technique, the child is placed under a general anesthesia. The femoral artery is catheterized with a microcannulation approach. The catheter is advanced into the ophthalmic artery, and the drug is pulsed into the ophthalmic artery with a micropulse delivery over approximately 30 minutes. You can see the initial procedure by the Japanese was to place the catheter up. They passed the ophthalmic artery and they used a balloon to occlude here in the carotid artery and backflush drug through the ophthalmic artery. Because of the concerns of occlusion of the carotid artery for this treatment, we were not interested in using this approach in Miami. It was the modification of this approach that allowed direct cannulation of the ophthalmic artery that was performed by Dr. Pierre Goban that allowed us to regenerate an interest in the use of this procedure. So it is the direct cannulation of the ophthalmic artery and the pulsed delivery over 30 minutes of the chemotherapeutic agent that we have employed as a treatment strategy in Miami at the Miami Children's Hospital. This is the Vasco Palmer Eye Institute experience in the first 12 cases that we treated. All 12 of these children had failed systemic chemotherapy, had active retinoblastoma tumor, and were scheduled for enucleation. Of these 12 eyes, 9 of them were able to be preserved without requiring enucleation and maintain some level of functional vision Only 3 of the initial eyes required enucleation, a remarkable response to this unique therapy. Unfortunately, with this unique treatment came a unique set of complications. At Bascom Palmer, we have seen periocular and inferior ocular rectus muscle inflammation. We've seen post-procedure vitreous hemorrhage. We've seen a Purchers-like retinopathy with choroidal infarction, and rarely we've seen low-grade neutropenia. So back to our 7-year-old child who presented with unilateral multifocal disease and 20/20 visual acuity. She received intra-arterial Malphilan chemotherapy, a single delivery of a 7.5 milligram dose, and direct laser to the tumor. You can see here the catheter being placed through the carotid artery under direct visualization. And this is the post-treatment response for the first treatment. You can see that the tumor is smaller. You can see some cotton wool spotting from the treatment and some focal hemorrhage, but the vision in this eye remains 20/20. We supplemented treatment here with laser over the tumor surface. The vision remains 20/20. And this child now on serial follow-up over the last 4 years has 20/20 visual acuity and maintains excellent function of this eye without compromise and has had no tumor recurrence. So here she presents in April of 2009, and 3 years later, now still 20/20 post-treatment. You can see the pigment metaplastic changes that are associated with changes in the choroidal vasculature, but the excellent tumor response. So in summary, this is a case of unilateral multifocal stage 5B retinoblastoma that was successfully treated with intra-arterial ophthalmic artery Malphilan chemotherapy without systemic chemotherapy and maintained 20/20 visual acuity. Unfortunately, there remain significant questions in the management of children with this disease. What is the best drug to use? What is the best dose of drug to use? How many cycles should we use to treat these children? What should be the interval between treatment, and how concerning should these complications be? At the Bascom Palmer Eye Institute and now at the Ocular Oncology Service in Miami, we use a unilateral and bilateral treatment approach so that children with bilateral disease are treated in a single session. We've shown that it's important to use high-dose Malphilan chemotherapy. We try to minimize the dose usage below 5 milligrams, and we treat every 3 to 4 weeks. We limit the total delivered dose based on an algorithm that utilizes body surface area and patient age. We've shown that for moderate disease, a single treatment may be successful to cure retinoblastoma and no further treatment may be necessary. So in conclusion, intra-ophthalmic artery infusion of Malphilan appears to be an effective tool in the advanced management of complex retinoblastoma and appears to have no systemic toxicity and an overall reduction in morbidity when compared with systemic chemotherapy. So in 2012, retinoblastoma appears to be a uniquely curable pediatric malignancy. It is the most successfully treated malignancy in childhood. There's been a huge evolution from enucleation to radiation therapy to systemic chemotherapy to focal chemotherapy. And this disease appears to be uniquely amenable to novel treatment strategies, including targeting tumor vasculature and hypoxia. What are our clinical pearls? You should expect at an advanced center that children presenting with Reese-Ellsworth stage 1 through 4 or ICR stage A through B, which is early stage disease, should have a 100% preservation of the globe with some degree of functional vision. You should expect even in advanced retinoblastoma, Reese-Ellsworth stage 5A and 5B, or ICR stages C and D, again, that all children should be alive and well, and that 85% of the eyes should be able to be preserved without the requirement for enucleation or radiation therapy. You should be aware that periocular chemotherapy delivery, particularly with carboplatin or topotecan, may be advantageous in increasing local tumor control in advanced disease. And you should be aware of the recent shift at many major treatment centers from systemic chemotherapy to intra-arterial chemotherapy in the hope of minimizing treatment-related toxicity and minimizing treatment-related morbidity for these very young children with complex cancer. It's important to understand that these are new studies and new data, and that alternative therapies such as we've discussed will require further pilot clinical trials, and those clinical trials are currently being evaluated for the treatment of children with advanced retinoblastoma, combining chemotherapy with vascular targeting agents such as 2-deoxy-D-glucose. And we hope in the future to go from this charming child who required her eye to be enucleated to this bright young man who's been treated with even more advanced disease but has kept both eyes and has excellent vision, in fact, in both eyes now in 2012 with follow-up approaching 5 years. I'd like to acknowledge the people at the Bascom Palmer Eye Institute, the Sylvester Comprehensive Cancer Center, the Jackson Memorial Hospital, particularly Doctors Ali Sultan, who's the interventional neuroradiologist, and Dr. Cristina Fernandez, who is the hematology oncologist. I'd also like to acknowledge Dr. Zayed Khatib, who is the Director of Pediatric Oncology at the Miami Children's Hospital. And finally, I'd like to recognize Dr. Arnie Marco, who's been the world's authority on the use of radiation therapy in pediatric retinoblastoma. My laboratory has been blessed with excellent people, including a collaboration with Dr. Ted Lampidas at the Cancer Research Center and my colleagues in the laboratory. We've been lucky to be supported by National Institute of Health Research support funding and funding from Research to Prevent Blindness and from Alcon Surgical. And I'd like to acknowledge the references that were associated with this presentation that are now available on the website for you. So at this point, I'd like to take an opportunity to thank all of you for joining us, and I'd like to see if we have any questions that we may be able to discuss. And for that, I'd like to invite Ms. Laura Malkin Stewart, who's been our host for this presentation, to join me.
Hola, buenas tardes. Gracias por haber estado aquí con el Dr. Murray. Si tienen alguna pregunta, les pedimos que por favor la escriban en el public chat. Y el Dr. Murray con mucho gusto contestará y yo le puedo ayudar a traducir si necesitan una explicación en español. ¿Tenemos a alguien que tenga alguna pregunta, por favor? Si alguien tiene una pregunta, pueden darle al botoncito, al círculo verde, que está en el barcode de abajo a la izquierda. A ver, Pedro Antonio, por favor, si quiere escribir su pregunta, o le podemos activar el micrófono. We can activate Pedro Antonio's microphone if you'd like to talk. Or la va a escribir aquí. A ver. Guess we could activate the microphone right there. And this one is right.
Pedro.
Aquí, buenas tardes. ¿Por qué la quimioterapia intraarterial puede producir inflamación del recto inferior? That would be, why does intraarterial chemotherapy produce inflammation in the inferior rectum?
So, when we do intraarterial chemotherapy, we're actually delivering chemotherapy through the ophthalmic artery to the eye itself, but we have chemotherapy that goes into the orbit and into the vasculature of each of the individual rectus muscles. It's unclear why the inferior rectus muscle appears to be inflamed preferentially, but you can imagine that this is an incredibly toxic chemotherapeutic agent and can have a local inflammatory response. So I think what's surprising is that these children tolerate this treatment as well as they do. It's important to recognize too that the controversy with the use of this treatment has been the vascular changes that can be seen within the retinal and choroidal circulation. And on the picture that's up, you see the optic nerve and the fovea. Here's the excellent tumor response that we've talked about, but you can see this almost sectoral area of pigment metaplasia that appears to be related to non-perfusion transiently within the choroid. Fortunately, we have not seen any short or long-term visual acuity effects with that, but it's important to recognize that that is a possibility.